what would you, this is super common, you need to, so what do you,
I mean, counseling, the situational, so hydration, don't
or
waste
hydration, what else?
hydration, deep breathing exercises.
I don't know about that.
I think anything which would increase your preload and not so
So you increase the salt
Salt
intake, increase
intake.
hydration, and then things that improve their their
Exercise.
reflex like exercise. But the other thing that people are, it's hard to get people to do is you tell them if you have a premonition, lie down. Don't sit down, that doesn't work. But you gotta get your head lower than your feet. You gotta get all that 1,000 cc's back in your central circulation. So it's hard to get people to do that. I mean, a common thing for me when I was in cardiology, Sunday afternoon, somebody be in church, standing up, be hot, singing, emotional, thinking about a loved one, and hit the deck. And you know, oftentimes they say, yeah, I tried to hold on to the pew, or I tried to sit down, but it didn't help. Of course it didn't help, because it didn't get any more blood flow to their head. So you need to tell them not to be embarrassed, to lie down, and get their head down, raise their feet. I mean, you know, you'll be standing in line in the movie theater and see somebody, and that's what you do, go and just lay them down and raise their feet up.
Yes, that's what I was thinking of too.
We have a guest
A
from
couple
East that's
of
going to give us
you
a
might
case.
know about the case, so you guys don't answer who know about it. So this is approximately 70-year-old patient who was admitted here about a month ago because his AICD was firing. He has a history of CHF with an EF of 15%, status post AICD. He was here a month ago with repeated firing of his AICD. Apparently that's what he was feeling, and his cardiologist was Dr. Crawford. They found out there was nothing wrong with his AICD. He was discharged to a rehab because he was badly deconditioned for the time that he was here. He was in the rehab for 21 days, and from there he went to a nursing home. His medications, of course, included Lasix and spironolactone. He was on a beta blocker. He was an ACE. He was on the whole 9 yards for CHF. Then he developed shortness of breath, was taken to one regional in Selma. And from there, this patient was transferred to Baptist South because he was Dr. Crawford's patient. So that was the only reason they wanted to send him here, so that she could see him. So this patient was a direct transfer to the floor. He was pretty stable, so he directly came to the floor. We were called at night. We went to see this patient at night, and he was in the room sitting with oxygen, and his daughter was by his bedside, and we were taking history. Both of them were giving history as to what happened while they actually went to Selma. So the patient himself was talking to me, and he said, while he was semi-reclined, he was talking to me, and he said that he was getting short of breath, progressively worse for a few days. He was in the rehab, and they were trying to walk him around, and he got more and more short of breath. And then over in the nursing home, according to the daughter, his blood pressure was running in hundreds by 60s. So they were not giving him Lasix because they were withholding Lasix because they thought it could decrease his blood pressure even further. So, and then the patient himself started talking. So he was talking to me, and then while talking, all of a sudden he started gasping. Taking really deep breaths, his face became flushed, his pupils dilated and fixed, and then he collapsed. Said no further, he had no palpable pulses, no carotids, no peripheral pulses, and was not breathing.
Okay, so let's just stop there. And who's next? Jordan, so what's your differential on this guy?
Cardiac arrest, PE. Those are the two
I
main.
think those are my first two. Now, what else besides, when you say cardiac arrest, you mean what? VF or VT, or what do you mean by?
Right, VT.
Okay. All right. And so, you pick some catastrophic things, and that's the right thing to pick, because the guy's a sick guy, he's got a defibrillator, so we're not thinking he's got neurocardiogenic syncope. Right, and so what happened with this guy?
Or his pupils.
First of all, did it look like he got a shock?
It didn't. He kind of crumpled into a tetanic position because his joints were very stiff when that happened. And it wasn't like he had a shock and then he came back to normal. No, it was like more like a tetanic contraction of his body. So we initiated a code blue and right over there, and he was not hooked up to telemetry at that point of time because he had just arrived to the floor. In fact, when we tried to turn him to put a hard surface beneath his bed, he turned in total. I mean, there was no flopping or whatever. He was totally contracted. So we did chest compressions. Richard did chest compressions and broke 5 of his ribs. But then he had returned a spontaneous circulation in about a minute. And we got a pulse on him, we got a blood pressure, which was normal, and he was breathing fine. And when he came back, I asked him where he was, and he said he was in Baptist South Montgomery. He was pretty much with it.
So what did you do at that point?
So at that point, well, we transferred him to the ICU. We hooked him up to a telemetry. We ordered an AICD interrogation. PE was very high on my differential because he was a nursing home resident and they were trying to move him around, but he was too deconditioned to be actually physically active. So we empirically put him on full dose Lovenox. I called MCA at night because it was Dr. Crawford's patient, so I had to tell them that he had coded at night. And so they agreed with putting him on full dose Lovenox empirically. And he was too unstable initially, but the next morning we ordered a CT angio on him, and it did come back as bilateral PE.
Right, so you did a massive PE.
He had a massive PE.
Yeah.
And he didn't have ETAR on interrogation. It was not.
He did.
Did. Got the bag?
And we write
All right, 65-year-old man with history of anti-traumatic injuries goes doing well, complaining of spasms, but she has blurred vision, lightheadedness during one of them passed out. So tell me what you're thinking on this guy.
Maybe embolism, maybe he has a history of MI, so sometimes the aneurysm may form due to the myocardial infarction, and thrombus may form and it dislodges anytime, and it can go to the brain, can get a stroke.
It could have, but usually after 3 years, if you had an aneurysm, the thrombus is going to have, it's going to be fibrosed. So that'd be unlikely to have a healthy thrombus.
Sure.
He might have had arrhythmias from the previous MI.
Yeah, I mean, I would worry that he's having a rhythm problem. That'd be the, he's had an intra-MI, usually big, usually involves some of the conducting system, and so you'd be worried he could be having heart block, or he could be having VT. That would be what I'd be worried about. So that would be somebody that, I mean, if I saw that guy in the emergency room and he had passed out, I'd admit the guy, wouldn't send him home. Now, if by the next day, next afternoon, he hadn't any rhythm problems, there's no point, and I wouldn't put him in the bed. I'd tell him to walk around with help, so I'm not wasting the telemetry. I'd send him home with an event monitor. So, okay. All right. 25-year resident from a foreign land complains of the vague chest pain condition while hiking in the Hindu Kush. He thought it was altitude related, but because of the single scout, he decided to come and have the GMS evaluated.
Angina?
Yeah, he's 25. Could be having angina. So in this situation, what do y'all think it is, vasovagal? I mean, some bad probably, right? So 25-year-old, pretty athletic up there and 14,000
Difference of
feet.
altitude because of the difference of altitude.
So you could have altitude-related, pulmonary edema, but that usually just makes it a short window. People with pulmonary hypertension, you can die suddenly, pass out and die suddenly. That's not at all uncommon. With bad pulmonary hypertension, either a rhythm problem or else they, for whatever reason, they dilate and they can't jack the cardiac output up like some with aortic stenosis. So what are the things you think of in this person?
Structural heart disease.
Structure.
Right, what structural heart disease would be?
Hypertrophic obstructive
Right, so
cardiomyopathy.
Hocum would be something I would think about, and Hocum's uncommon, but, this is a young person with an uncommon problem. And the other thing I would think about
Aortic
would be
valve, bicuspid aortic valve.
aortic valve, but that, bicuspid aortic valve doesn't present till age 50, 55.
Mitral valve prolapse.
Well, simply with bad prolapse can have really significant rhythm problems, but that'd be likely you'd know about it. I mean, the other thing would be, do they have does he have chest pain and shortness of breath, does he have a coronary anomaly? So those are the, when somebody has syncope when they're exercising, then that's generally something pretty significant. I mean, you can have somebody have a vagal spell during the middle of exercise and pass out, but that'd be much less common. And you'd certainly want to rule out everything else first. So, if it was a 10-year-old, the pediatric echo people can see with it, not much, we can't in adults, they can see the coronaries a lot better just with the transthoracic. So they look at the coronaries and see if there's any, like Hocum, any structural problem. And then obviously, they could, the resident could be having any kind of rhythm problem. I mean, people with SVT, super fast, or WPW can go super fast, that atrial fib. I mean, you got to think about all that also. Okay. 60-year-old diabetic man with angioedema and ICD placement is 2 months out from placement of multiple drug-eluting stents. Gets up from a nap and passes out on his way to the bathroom. Spouse says his eyes rolled back in his head and he shook all over during the episode.
Differentials would be seizures, and also the second will be orthostatic.
Okay, it could be
Autonomic.
orthostatic. And why do you say seizures? Because he shook all over? People that have syncope, that have decreased perfusion long enough will have usually myoclonic jerking. I mean, if you stay out long enough, you have seizures. But so I wouldn't be thinking of seizures first off. So I would think it was orthostatic. You know, he's on a lot of medicines. But what else would I be? I mean,
Autonomic dysfunction from
could be that. Probably he's
pulmonary
diabetic.
embolism.
Okay. And then would you do a rectal exam on him? If he was not bleeding, you got him all these antiplatelet medicines. Okay, so don't
Yep.
forget, don't just, somebody's got heart disease, they can still bleed like anybody else, so, okay.
What was dissection, Dr.
He could have a dissection, but, I mean, I think you got it, that would be in my, like, the catastrophic versus non-catastrophic, and I think if I didn't come up with something early on, I'd think about dissection. Okay, this is a patient on here. 50-year-old lady, anyway, she had a secundum ASD. She was particularly didn't want to go to here or to UAB. She wanted to go to Cleveland Clinic and have just kind of the non-minimally invasive surgery. So she went there, had the ASD closed, came back, and she was having some shortness of breath and lightheaded. She called the Cleveland Clinic nurse. They said, "Don't worry, we never make mistakes at Cleveland Clinic." That night, her spouse, knowing it saved her, she fell in the kitchen with it, made a big noise. So he went in there and kind of watched her, and she woke up in a few seconds. She came to Baptist South and asked for a GMS resident to evaluate her, and she had to be the night call.
She had thromboembolism.
All right, so that would be a big
Travel through
big
PhD.
differential, that she had a big pulmonary embolus. Okay, what else?
Arrhythmia.
She could have arrhythmia, but people with ASDs, usually the heart's pretty, I mean, people with ASDs, even after they get repaired, they risk atrial arrhythmias their whole life. Atrial fibrillation, flutter, but they're not prone, I mean, they have a normal ventricles and they don't usually have ventricular arrhythmias.
Procedures.
You what now?
P-
Yeah,
Proceed.
tamponade. Okay, so that was kind of worried about both those things. Got a stat echo, and she, I mean, her physical exam was compatible with tamponade. So, anyway, Dr., y'all know Dr. Sowers, but he wasn't too pleased when I called him, 3 in the morning. I didn't send you this patient, but I want you to take care of him. So, anyway, she had tamponade and passed out from that. And, anyway, so that's the setting post-op, that's the pulmonary embolus tamponade. Okay. 18-year-old lady, when Esther comes to see you in clinic, recurrent palpitation, passed out once when a car backfired next to her. She was separated from her family shortly after birth and tried to connect recently, but found out that one sibling drowned and the other one died at an MVA.
Situational or?
And when somebody says hope, no, I hope.
Seems more situational or.
Well, it could be situation the car backfired, but she said palpitations, she said recurrent palpitations, that's not what goes along with situation. I'll give you another clue.
She drinks
Anxiety.
caffeinated
Does she
drinks,
what now?
a lot of sports drinks,
No.
caffeinated drinks, no.
But that's a good, because believe me, no, I mean, these sports drinks, there was a lady that was in the Boston Marathon, the London Marathon recently did one of these new sports drinks that basically had a lot of sympathetic amines and died. I'm a 20-year-old.
Could be post-traumatic stress.
My two siblings are.
And who said QT prolongation?
Yeah,
Okay, well, now, why did y'all say that?
because one sibling dead, another died.
Right, okay, so that's exactly, so that's right. So if you don't ask people, you're gonna miss it. So you got, in the family history, and somebody that passed out, I mean, you gotta look at the QT interval. You gotta ask them, is there family history of sudden death, or if they say, no, well, what about death in a wreck or drowning? Drowning is common with QT prolongation. Some die after sudden noise, some die drowning, depending on what mutation they have. So you got to ask them congenital deafness, Romano Ward, about that kind of stuff. You
Is
got
there
to.
any QT which is more common, like QT1, 3, or?
I have no idea. I have to look. I mean, if I thought she had that, I'd be scouring to see which one she had. But I don't remember that off the top of my head. But the other thing, remember on the QT prolongation, just like on Brugada, you might not see it on the first EKG. You might have to repeat the EKG, and so. All right. So let me go over one other thing. So let's just suppose you have the diabetic guy in your clinic, and diabetic hypertensive, he's on some hypertensive medicine, but he tells you that every time he gets up, he's getting really lightheaded, and he's just about passed out several times. So he's got autonomic insufficiency. You tilt him, he's got a big drop. So kind of what are the things that you do to get around that?
Ask him to sit for a couple of minutes before he actually gets up.
No, I don't think that's going to do it. Okay, well, you use compression hose, that might help some. The first thing I do is look at his medicines. And that's a situation where the guideline might say 140 over 80, but if he's going from 140 to 100 and passing out, then you're gonna have to let him have a little bit higher blood pressure. So the first thing I might do would be to back off from his diuretic, if you could tolerate that. And then it might do it on other medicines. So let's just assume we juggle his medicine and that we increase his salt that doesn't help. We give them support hose, what else can you do?